Welcome to the Owning Your Sexual Self podcast. I'm your host, Rachel Main, awesome wife and dog mom for life. I'm a sex therapist turned sex coach, and I run a successful business selling relationship enhancement products. I absolutely love talking about all things sex. So you can expect this podcast to explore all things related to women's sexual health because that's what I'm here for. I'm here to help you discover and embrace what brings you pleasure so that you can own your sexual self. If that sounds good to you, then keep listening and let's fucking do this. All right, everyone, welcome back to the Owning Your Sexual Self podcast. As you heard, I have an awesome guest on with me today. I have with us Jill Krapf, who is all the way from the DC area and it works in gynecology as well. And we are talking, so one of the common things that I get from people that listen to the podcast and the women that I work with is this pain during sex. And so today that is our primary focus of this and talking about why this pain might be coming to you and also the different types of pain and of course some guidance around how to help manage that. So thank you so much.
Thank you for having me. Yes. So yes, I'm a gynecologist by training. I trained as an obstetrician gynecologist, but I no longer deliver babies. I spend my full time now just treating women with sexual pain and vulvar pain conditions. So any conditions of that area is what I do now. But I can tell you a little bit about how I got into this field because not many OBGYNs or doctors really do what I do or specialize in this area.
Yeah, absolutely. And I love hearing just everybody's story that works in this field because I always feel like it comes from some special place within them. So yeah, tell us, how did you get into this line of work or what led you to here?
Yes. So I did a residency in obstetrics and gynecology after I completed medical school. And the residency for OBGYN is typically 4 years. And when I was in my final year, I was about to graduate and go out into the world as a practicing doctor. And I was scheduled to operate with one of the private doctors who was in town. And he basically practiced sexual medicine, and he was doing a surgery that I had never really seen or heard of before. He was doing something called a vestibulectomy, and it's for a certain type of vulvodynia or pain condition. And so I spent the surgery with him, and he taught me about vulvodynia, which is pain, usually pain with sex, and it was something that I had no background in. It wasn't covered in my residency training. I was about to go out and take care of women on my own. And I just couldn't believe that I didn't know about something that seemed to be really impactful and very important. And so I took it upon myself to spend about a day a week with him for an entire year, just learning about how to do this. And I was so caught up with it and so interested in it that when I became faculty at the institution where I was practicing, I actually started a Center for Sexual Health. And I was the female division, and then there was an older gentleman who was very experienced, like 35 years in private practice, who came back to academics, and he was seeing all the men for their erectile dysfunction, and I was seeing all the women, and the need was there. I had women traveling from far away to come and see me because there's not many providers that really do this, and especially female providers. And at the time I was accepting insurance, and there were really no one that was really doing that except for maybe a handful of people. And so that's how I got into it. And then finally, after doing that for a while, I made the life decision that I just love doing this so much. I want to dedicate my entire career to it. I just don't want to do it 1 day a week or 2 days a week. I want to do it every day. And so I gave up obstetrics and I stopped delivering babies. And then this is what I do full time, in addition to a lot of research on the topic, a lot of writing, and then participating in national conferences and national education.
That is amazing. And it's so amazing to me too, these people that I have on the podcast that are doing this type of work. It's almost like we get this light bulb moment in life where it's like, this is what I'm meant to do. This is like you said, I want to dedicate my life to this work. I mean, that is such a powerful thing. And I know from, again, the women that come to me and that I'm working with, pain is almost always something that comes up for them and that they have questions about. So the fact that you're able to provide that care that so often we feel worried about, to ask questions to a primary care provider, sometimes even our gynecologist, it sounds like you are really that type of person that's opening that door and allowing people to ask those types of questions.
Absolutely. I think it's so important. And these are such sensitive topics. It's hard to go to your doctor and reveal the most intimate details about your sex life or your relationship. And so I've always, even when I was younger and I knew that I wanted to be a doctor, the thing that appealed to me about being a doctor was really connecting with people in that way. Mm-hmm. I'm a good secret holder. And so I really love, really connecting with someone and being a trustworthy person that they can really rely on to tell these things. Because with what I do now, I need to know what's going on in order to figure out how to solve the issue that somebody's having. So if someone has sexual pain, I really need a full history, and I need to do a very intimate exam to really untangle what is going on. And there's not always physical concerns. There's sometimes psychological factors that are impacting it, or history of abuse and things that people don't tell anybody at all. Mm-hmm. I've had women who have sat across from me and said, I've never told anyone what I'm telling you now, and this is the first time we're meeting. Mm-hmm. And I do not take that lightly. I mean, I really, really feel very thankful that I get to be in a position where women have that type of trust in me.
Mm-hmm. Absolutely. And that is a real gift too. And being on that same end, and when I was previously working in therapy, and when somebody has that authenticity with you and that trust in you, especially on that first meeting, I mean, that is so magical is the word that's coming to mind, because all of the work that can be done after that, so often we don't speak what's going on up front right away to our providers. And then it's almost like being on the other side, it's like we're trying to pull back these layers and we're almost trying to figure it out on our own, when it's so much easier if we can just let it all out on the table and get that full background history and whatnot. So now in your work today, what are the types of people that you are seeing primarily in the clinic today?
Yes. So most women come to see me because they're having pain in the vulvar area or the vaginal area. And I would say the most common reason that actually really prompts them to come to the office is if they're having pain with sex. And if it starts to affect their relationship, whether that be with partners or whether that be with themselves, that's what really gets them to my door. Mm-hmm. Because they can be suffering with different, discomforts and things like that. But when it really starts to affect quality of life, that's when I see them. And when we're talking about sex, there's different types of sex, right? Mm-hmm. We all know that it's not penis and vagina all the time, but I have to say that when a woman comes to see me, what she's usually talking about is pain with insertion. Mm-hmm. So she is talking about pain at that vaginal entrance area with any type of insertion, whether that be with her partner or a tampon or a speculum or a dilator. So that's usually what I see.
Mm-hmm. And what would you say are often the causes of somebody that's experiencing pain in this area?
So there's many different causes. And so when we're talking about pain in this area, I like to divide it into different areas. So when someone's having pain with sex, the medical terminology for that is something called dyspareunia. And that basically means pain with intercourse. Now that pain can be deep or it can be superficial. When the pain is deep, it's usually I'm having pain with deep thrusting, or I feel a sharp pain on the inside. And most of those causes are actually structural. So if you think about things that are inside the body or inside the pelvis, so examples of that would be things like endometriosis or scar tissue from a previous C-section or other surgeries. Or you're thinking perhaps it's the tilt of the uterus and how the cervix is aligned with the uterus that's causing some sort of discomfort from a structural standpoint. So or a cyst on the ovary. So these are the structural things that we think of when we talk about deep pain or thrusting pain, also called deep dyspareunia. Now, the pain conditions that I often see are the superficial dyspareunia, or pain at the vaginal entrance with insertion. And that is a majority of sexual pain. It probably makes up over 80% or maybe even higher of sexual pain. And most of that actually gets labeled as vulvodynia, or the more specific term would be vestibulodynia. So I'll tell you a little bit about what those are, because we throw those terms around a lot, but it's not always obvious as to what they mean. So vulvodynia basically means pain of the vulva, or an abnormal pain response of the vulva. And that's really broad. That's basically just saying where the pain is located. It doesn't tell you what is causing the pain. Sometimes doctors or patients will use that as a diagnosis, and they say, my diagnosis is vulvodynia. But vulvodynia really isn't a diagnosis. It just tells us where the pain is. And so oftentimes when we talk about vulvodynia, there's an idea of that it's a pain that we can't identify the source, right? It's all the common things have been ruled out. Like, for example, you've seen your gynecologist and she's done cultures, and you don't have a sexually transmitted infection, and you may not have endometriosis, or you may not have some of the other more common things that we look for, and then, oh, you must have vulvodynia. But the problem is that when we don't know what a cause is, or something's like a big black box mystery, it's hard to treat it because we don't really know what we're treating. And that has been the case with vulvodynia historically. Now, what's good is there's specialists and there's research in this where we're really determining what the factors are, or the potential causes are, to try to untangle this and try to figure out what actually is behind a person's pain with insertion.
And so when somebody is coming in to see you, what can they expect once they get into the office?
Yes. So my consults, they take a while because it takes a long time to basically collect a history, to do an exam, and then to educate and to go over a long-term and thorough treatment plan. And so I dedicate an hour and 20 minutes to all of my new patients. And sometimes it takes a little longer, and sometimes it takes a little shorter, but I think it's important to have that time. It's also important that because I am at such a specialized center, patients have seen an average of 7 doctors before they come to me. So it's a little bit different than a normal OBGYN office. I have patients who fly to see us from all over the country, even all over the world. And so it's very specialized. And so it takes time. I need to review previous records. And oftentimes it takes time and thoughtfulness to go through a person's history. But that's where I start. I start with, after we talk a little bit and get to know each other a little bit, I go through their baseline history just to understand what medical problems someone has, what medications they're on. All of these things could be clues to why they're having pain in this area. There's certain medications that cause dryness of the glands that produce our natural lubrication. There's certain medications that cause decreased sexual desire, which can affect arousal and can lead to pain. And so my brain is constantly working when I'm listening to someone's history and asking them these questions. And then we talk about the history of their pain, who they've seen, what they've tried. I ask them what they think it's related to. I think that's really important. And so we basically sort through all of these things. And then after that, we typically do an exam to try to figure it out.
Yeah, so very extensive. And I'm glad that you mentioned that on average, people see 7 other doctors before seeing you. And I'm sure that along the way, you've probably heard, gosh, I wish I would have just came to you first. And I think that just says something about us being able to, first of all, if you're using insurance, they make it very hard for us to even go directly to a specialist. Oftentimes it's like we feel we have to jump through so many hoops to even get to the person that is actually going to help us.
This is true. And insurance is a tough one. I worked in an insurance model for over 10 years. And so I'm very familiar with different models of service. But I ran sexual health clinics within insurance models. And ultimately, I just felt like I wasn't doing the patient a service, and it wasn't gratifying or satisfying to me because I didn't have the time necessary to really get to the bottom of someone's pain. Mm-hmm. And so right now I do work in a model where we are out of network providers, mm-hmm. but it also frees me up to be able to treat a patient in the way that they need to be treated, and in a way where I feel really good about their care, and I dedicate everything to it. And so it works. I mean, there's definitely pros and cons with each model, but I think when it comes to something very specialized, such as vulvar pain, mm-hmm. then this is probably the best model to work in.
Yeah, absolutely. So this has all been so helpful, and I'm curious, what do you mostly see as the different types of the causes of this pain that people are experiencing?
Yeah, so I like to really break it down because I think when patients really understand why something is happening, then number one, it decreases a lot of the unknown about it and a lot of the anxiety that comes with that unknown. And it also helps us develop a treatment plan that's going to work, and it allows us to have buy-in so they understand why they're getting a certain treatment and then why they're doing it in a certain way. Mm-hmm. And so I spend a lot of time in my consultations really educating. I was a medical educator for 10 years. I still am, but I taught medical students how to be OBGYNs. I was a associate clerkship director for a number of years in 2 different academic institutions in major cities. And so I really just dedicate all of that to my patient now. And I really treat my patients with the same respect that I treat medical students, and I educate them in the same way. And I think that's really important. And patients really appreciate that too. Because oftentimes actually the women that see me are more expert in this than some of the medical providers that they've seen in the past, just because it's affecting them and they've read so much about it. Mm-hmm. So I totally respect that. And so I talk to them in that way. Yeah. But the way that I break this down in my head is that when we're talking about pain with sex at the entrance, so with insertion, we call that vestibulodynia, because the entrance to the vagina is called the vestibule. Odine was the Greek goddess of pain, and so vestibulodynia refers to an abnormal pain response of the vaginal opening or the vestibule. And that's most of the pain that people have with intercourse. It's usually at the entrance. And so when we're thinking about that, I like to put it into 4 different categories. And somebody can have more than one category. That's a possibility. Mm-hmm. So the categories are typically hormonal, muscle-related, nerve-related, or inflammation. Now, the one thing that we're not going to cover right here, because we're talking about the main categories that are biologic or physiologic, if you will, or how the body works physically, is of course the psychological component. Yeah. But we'll kind of table that and kind of get back to how that fits in, because that affects every single category, of course. But when we're talking about these 4 categories, so hormonal, I see this across someone's lifespan. So I see this in postmenopausal women. So women who've gone through menopause whose estrogen levels have completely dropped, and then they're not getting the estrogen and the androgens, which is testosterone, at those gland openings that produce our natural lubrication. And those gland openings are located in the vestibule, which is that vaginal opening. So when the hormones are low in that area, it causes a dryness and it makes that tissue very thin and easily irritated and more susceptible to infection. And so someone can have a rawness, dryness, discomfort with intercourse related to hormonal reasons. I see this in younger women as well due to certain medications. So any medication that's going to decrease your estrogen, your androgen, or testosterone levels can have a similar effect, similar to what we see in menopause. And these medications are mainly birth control pills. Not for everyone. There's a small percentage of women who develop almost like a side effect, where they're very susceptible or they're very affected, like a side effect would be, to birth control pills, where they have a lot of dryness. And I think that has to do with their testosterone receptors in that vaginal opening area. I think some people just by birth genetically have weaker receptors and some people have stronger receptors. And if you're someone with weaker receptors and you challenge the system with a medication like a birth control pill or spironolactone, which is an anti-testosterone medication used to treat acne, when you challenge the system, then you can get those side effects or those unwanted effects leading to pain with intercourse.
Yeah.
So that's the hormonal bucket. And then we have muscles. So it's possible that the pelvic floor muscles, which surround the vaginal opening and span from front to back to hold everything up in the pelvis, sometimes those muscles can get tight or clenched. And there's different reasons for that. But that can form a cycle. A pain cycle, basically, where those muscles are tight, and that leads to lack of oxygen to the area, which leads to a burning sensation. And then the burning sensation makes you tighten up even more. So around and around it goes. These are the two most common reasons I see why women have pain with sex. It's usually hormone related, along with a muscle factor. And it's hard to say what came first. Usually the muscle is probably responsive, but sometimes it's hard to tell. And then the third bucket is nerve related. This is less common, but it's why people come to see me as a specialist. So we have nerves that come and feed through the pelvis and to the vulvar area. So sometimes there can be issues or irritation with a branch of the nerve or one side of the nerve, or even something in the spinal cord that is being irritated, and then it goes down the line and it causes issues. Sometimes with nerve related things, what we'll see pain on one side versus another, and that clues me in to think that it might be something nerve related. Or if someone's having pain of the clitoris, then that really clues me in that there's probably some sort of nerve component to this. And then the last bucket is inflammation, and that's a pretty large area right there. But inflammation, the way that I think of it, it can be internal or it can be external. What do I mean? I mean, internal is autoimmune skin conditions that can cause symptoms or tightening or change in the anatomy in that area. It can cause tearing and things like that can lead to discomfort with intercourse. And then external causes of inflammation are usually things like infections. So we're talking about recurrent yeast infections, bacterial vaginosis, aerobic vaginitis, or desquamative inflammatory vaginitis, which is an extreme form of vaginitis that's very irritating. So that's how I approach it. And like I said, there can be more than one thing going on. The important thing is to unravel that ball of yarn and to figure out what the causes are. Once you figure out the exact causes, then treatment is easy. We have treatments for all of these things. So that's the general idea.
I love that. And I'm glad that we can talk on the physiological side of it, but I love that we kind of put that aside, because so often I feel that women are told when they're experiencing this type of pain that it's all in our head. And we know that can be a piece of it, but there's also this very real piece of everything that you've just covered in the last 20 minutes, that there's also very much a physical side to this, and that there are people out there that can help you figure out what is causing this. And now to even hear that there are treatments for all of these things, that I imagine somebody that might be going through sex therapy to talk about what they're experiencing in the relationship because of this pain while working alongside of you, that is like the ultimate combination for success for somebody around this area.
Absolutely. And the other thing that we need to remember is that being in pain and having discomfort or daily burning or pain every time we try to get intimate with our partner, that also causes a level of stress, anxiety, and even depression can result. And so there's a responsive element to all of this as well. And I've done actually some research in this area. So I'm very interested in the idea of pain-related anxiety. So pain-related anxiety is different than generalized anxiety or the anxiety that we typically think of. Pain-related anxiety is this idea that you have an acute pain source and then you treat it like a yeast infection, right? You treat it and it goes away and you say, okay, there we go, that's fine. Now, what if you had that yeast infection and you treated it and it went away a little bit, but then it came back, and then you tried to treat it again and the symptoms didn't go away. And then all of a sudden it becomes something that you start thinking about every day. And then it's affecting your intimacy, and it's affecting the clothing that you're wearing, and it's affecting how you sit and then how you interact with people. And you don't want to go out and do something social because of this discomfort. And then all of a sudden it becomes almost like a cycle because it's causing a pain-related anxiety. And that pain-related anxiety is having physical effects as well because it's causing you to tighten up and clench your pelvis because you're constantly uncomfortable. And then it kind of puts you in this physical pain loop fueled by a psychological component of the anxiety adding fuel to the fire. And this is the idea of a pain-related anxiety contributing to the physical. And not a lot about this is known in the research, which is shocking to me. At least when it comes to vulvodynia, it's not. There's probably a lot more in the pain research in general, but it really hasn't been really well explored in this area. And I think it absolutely needs to be. So instead of saying, oh, you're anxious, that's why you developed vulvar pain, I think we need to say, you have vulvar pain. Anybody would be anxious if you had that and no one could figure it out, and you've been to 7 doctors and no one knows what you have. So I give my patients a lot of credit because I think that anybody would feel that way if they were confronted with such a challenge.
Absolutely. And I love this whole conversation has just normalized so many things for, I know, everyone that's listening today. And so as we are closing, I'm wondering what advice would you give if somebody's listening to this right now and they're in that boat where they've been doctor after doctor, or maybe they haven't even mentioned it to somebody. What would you say to them?
So many times the pain has a muscle component of some sort. And so I realize that there may not be a vulvar pain specialist or someone that does sexual medicine in your area. But it's important to start somewhere. And it doesn't feel good to bring it up to your general practitioner and have that person look at with you like you have 3 heads, and then you feel more uncomfortable and more alone. That doesn't help. So I think the best thing to do is pelvic floor physical therapists are wonderful resources, and they are located in many, many, many different areas. And they're often a bit easier to find or easier to get to than perhaps a sexual pain specialist. And so I would start there because oftentimes there is a muscle component. Even if there's not a muscle component, at least that person can direct you because they get referrals from the gynecologists and the providers and urologists in the know from the community. So they can say, okay, well, I evaluated your pelvic floor. I don't think you have a muscle component, but I've seen a lot of this, and this doctor over here usually sends me patients, so I know they know how to treat it. And so, it's all about, logistically finding resources. In addition, there's some directories that are available that are very helpful. One of directory is called the National Vulvodynia Association directory, and I can give you the website for that to share with everybody. So that's a good resource. There's some physical therapy directory resources that are very wonderful. One of them is Pelvic Guru. So they have great resources. My Pelvic Floor Muscles has great resources. So these are places to start. There's also some patient advocates that are on social media that have created Vulvodynia resources as well. And then another great resource is actually my practice webpage. We have a lot of information on the conditions that we treat. It goes into great detail. We have full text articles of everything that we've published, because sometimes these articles are actually really hard to see, more than just an abstract. It's hard to read these things. And so we have those available, as well as webinars available on our practice webpage, and that's www.cvvd.org or www.vulvodynia.com. Super easy to remember.
Yes, and we'll definitely link that in the show notes as well to make all of those things easily accessible for everybody listening. And of course, how can we find you and how can people get in contact with you? Because I discovered you through the world of social media, and I absolutely love your page and the things that you share. It's been super, super educational for me, even being in this field.
Thank you. Yeah, so I have an educational Instagram page. I'm at Krapf, MD, so it's just my name, and I'm sure you'll link that. So people can check that out. I post educational content on all of the conditions that I treat, and then through my website as well.
Absolutely, which is the vulvodynia.com. Easy enough to remember. Great. Well, thank you again so much, Jill. This has been, again, so informational and so educational, and I know normalized so many things for people. And again, just now for people listening, knowing that there is people out there that can help, and it's just having the conversation with people and getting in the right hands.
Yes. Thank you so much for having me.
Absolutely.
Thank you so much for listening to today's episode. If you loved it, be sure to subscribe so you never miss a thing. And if you loved it so fucking much, be sure to leave a 5-star review. I'll see you next week, and until then, keep owning your sexual self.